Assalamualaikum and hi everyone. In this presentation, we want to share with you some knowledge about pathology of granulomatous pulmonary disease. First and foremost, what is granuloma? Granuloma may be defined as compact, collection or group of mature mononuclear phagocytes such as macrophages or epithelioid cell, which may or may not be accompanied by accessory features such as necrosis or infiltration of inflammatory leukocyte. These granuloma form from a cluster of immune cells in response to chronic inflammation or infections in the lung. There are two types of granulomas, which is necrotizing and non-necrotizing granulomas. For necrotizing granulomas, most commonly caused by infectious agents such as mycobacteria and fungi, and non-necrotizing disease is caused by non-infectious conditions such as sarcoidosis and berylosis. For necrotizing granulomas, central necrosis is prominent features. Granulomas typically necrotizing and casseting, which is cyst-like appearance that can be seen macroscopically. Differ from necrotizing, non-necrotizing granulomas. For the central necrosis usually absent with well-formed granulomas. So how does necrosis in granulomas form? It forms when granulomas inciting agent such as acid fast bacilli, fungi and etc. is highly toxic to the macrophages, and it also can be caused by vigorous delay hypersensitivity is provoked. Last but not least is the necrotizing granulomas is composed of macrophages, necrosis and lymphocytes, while for the non-necrotizing, it composed of epithelioid cells or macrophages with or without giant cells.
Assalamualaikum and hi, my name is Nur Husnina Hanin and I will be explaining the pathophysiology of granuloma formation. Granuloma formation is typically triggered by three main factors: persistent infection, immune-mediated disorders, and foreign substances. Persistent infections include examples such as Mycobacterium tuberculosis and fungi like Histoplasma capsulatum and Cryptococcus. Immune-mediated disorder include conditions like sarcoidosis and Crohn's disease. Foreign substances such as inhaled particles like silica and beryllium can also act as triggers. The immune response in granuloma formation involves both innate and adaptive immunity. First, in the innate immune response, macrophage and dendritic cell recognize the persistent antigen through pattern recognition receptor (PRR), such as toll-like receptors (TLR). For example, in TB, TLR2 and TLR4 detect components of Mycobacterium tuberculosis. This recognition leads to the release of pro-inflammatory mediators such as tumor necrosis factor alpha, interleukin-1 beta, and interleukin-6, which recruit other immune cells to the site of infection. Next is the activation of adaptive immunity, where macrophage and dendritic cell present the antigen to naive CD4 plus T cell using MHC class II molecules. This presentation causes the naive CD4 plus T cell to differentiate into Th1 cells, a process influenced by interleukin-12 released from antigen-presenting cells. These Th1 cells then secrete interferon gamma, a crucial cytokine that activates macrophage, enhancing their ability to eliminate the persistent antigen. Continuing the discussion on granuloma formation, the hallmark of this process is the recruitment and activation of immune cells to form a structured and localized mass. At the core of granuloma, activated macrophages transform into epithelioid macrophages, which are large, flattened cells with enhanced phagocytic activity. Some of these macrophages fuse to form multinucleated giant cells, such as Langhans giant cells, which are arranged in a circular pattern and enhance the ability to contain persistent antigen. Surrounding this core are layers of immune cells and structural components. Th1 lymphocytes form a layer around the macrophage, maintaining immune activation by secreting cytokines such as interferon gamma. In chronic granulomas, fibroblasts are recruited to the periphery, which they secrete collagen and form a fibrous capsule, adding structural support. The fate of granuloma depends on the balance of pathogen persistence and immune regulation. If the immune system successfully eliminates the triggering factor, the granuloma resolves, with macrophage and lymphocyte clearing out and normal tissue being restored. However, in some cases, chronic granulomas lead to fibrosis, characterized by excess collagen deposition, which may leave permanent scarring in the affected tissue. Persistent granuloma, as in infections like TB or disease such as sarcoidosis, may result in prolonged inflammation, causing tissue damage and potential organ dysfunction. In certain situations, granulomas may break down, leading to the dissemination of infection or trigger. For instance, in TB, caseous necrosis within the granuloma can rupture into airways, spreading bacteria and worsening the disease. And last but not least, this is the example of the process in flowchart which I have explained in the previous slide.
I will be explaining about the inclusion bodies. Begin with, inclusion bodies are intracellular components found in the immune cells that form granulomas in the lungs. Granulomas, which are clusters of immune cells like macrophages, develop as a result of long-term inflammation. In addition, inclusion bodies in the lungs can form for two main reasons. Firstly, infectious agents such as fungal infections can lead to granuloma formation. Secondly, immune responses as seen in sarcoidosis trigger granulomas as part of the body's exaggerated immune reaction. Moving forward, we will dive deeper into specific type of inclusion bodies seen in granulomatous pulmonary diseases. Next, Schaumann bodies are rounded, laminated structures commonly found in granulomas. They measure between 25 to 200 micrometers and are typically located inside multinucleated giant cells. Furthermore, these bodies are made of mucopolysaccharide matrix containing calcium salts and iron. In addition, they are often associated with colorless crystals that reflect light under polarized microscopy. As for their prevalence, Schaumann bodies are seen in up to 50% of sarcoidosis cases and are also present in conditions such as hypersensitivity, pneumonitis, and berylliosis. However, it is important to note that while they are helpful for diagnosis, they are not specific to one disease. As seen in the images, Schaumann bodies are round, onion-like structure with concentric layers. Now, let us move on to the formation and significance of Schaumann bodies. Over time, these bodies grow larger and can eventually break into the surrounding tissue. Inside, they contain crystals made of calcium oxalate and calcium carbonate, which act as a core for the body's development. So they provide supportive evidence but are not definitive for sarcoidosis. Moving on to the crystalline bodies, another type of inclusion found in granulomas. These structures are typically non-laminated and irregular. Under polarized light microscopy, they appear birefringent, meaning they reflect light brightly within the cells. In terms of composition, crystalline bodies are primarily made of calcium oxalate and calcium carbonate. Furthermore, these inclusions are found within the cytoplasm of multinucleated giant cells that are part of granulomatous structure. When it comes to prevalence, crystalline bodies occur in 41% of sarcoidosis cases, 15% of chronic beryllium, and 3% of tuberculosis cases. Now, let's discuss asteroid bodies. These are star-shaped inclusions with up to 30 rays radiating from a central core. They are composed of cytoplasmic filaments and cellular debris, sometimes surrounded by lipids or other cellular materials. In terms of location, asteroid bodies are found within the giant cells of foreign body granulomas. It's important to note that asteroid bodies do not confirm sarcoidosis as they are not disease-specific. Instead, their presence supports the formation of granulomas. The image here illustrates their distinct star-shaped structure under the microscope. Let's focus on cholesterol inclusion. As shown in the images on this slide, first, in the image on the left, you can see slit-like structure within the giant cells. These structures are elongated and irregular. This highlights their unique shape and appearance in histopathologic samples. Although these inclusions are seen in up to 17% of sarcoidosis cases, they can also be found in other granulomatous conditions. It is important to note that their origin and formation are uncertain, but they likely result from cholesterol crystallization. Hamazaki-Weissenberg bodies, a type of inclusion found in granulomatous lymph nodes. These bodies are tiny, spindle-shaped or oval and stained yellow-brown with H&E due to their lipofuscin content. They are found outside cells in granulomatous lymph node and are not present within giant cells, which makes them different from Schaumann or asteroid bodies. For staining, they can look like yeast under Graucoat methenamine silver stain, but they are negative with ZN, ruling out fungal or mycobacterial infections. As shown in the images, the left one shows they are yellow-brown color under H&E staining, while the right one highlights their yeast-like appearance under silver staining. Next, last but not least, the prevalence and significance of Hamazaki-Weizenberg bodies. These inclusions are reported in 11% to 68% of sarcoid lymph node and 11.5% to 15% of granulomatous lymph nodes involved with other conditions. However, in terms of significance, it is important to understand that while they are common in sarcoidosis, they are also found in other granulomatous disorders. They are not specific to any one disease and should be interpreted cautiously in the context of other clinical and pathological findings.
Next, we proceed to the disease association of granulomatous pulmonary disease. For mycobacterial infection, tuberculosis granuloma is present that indicate the host response to infection. So, immune system will recruit more macrophages, T lymphocytes and other immune cells to the infection site that will lead to the formation of granulomas. So, how to detect this mycobacterial infection, tuberculosis? By performing radiologic finding like chest X-ray, green sputum smear, culture, PCR, ZN, acid fast stain, and fluorochrome staining using RMIO. Granulomas are present in infections caused by species of fungi, including Histoplasma and Cryptococcus. But for Candida and Aspergillus, usually cause acute inflammation and inciting granulomas. For diagnosis, fungal granulomas often separatists. It also can use in H&E staining, Graucoat methenamine silver stain, but for the gold standard is by performing culture. By using the culture, it can identify morphology features like the presence or absence of patin, pseudohyphae, and endospore. Next, for the parasitic infection, we harbor the adult form of Deirofilaria immitis and produce microfilariae that are shot into the bloodstream. Mosquito, the intermediate host, become infected with microfilariae when they bite the natural host. Microfilariae will develop into L3 larvae in the mosquito. When the human are bitten by the infected mosquito, the L3 larvae will develop into the immature adult and migrate to the right ventricle. Then it will immobilize to the lung. To detect this infection is by performing the chest X-ray, sputum and stool examination and using the PCR.
My name is Imaina Aina and I will continue about diseases. The next category is hypersensitivity diseases and the first one is berylliosis. Berylliosis is a rare occupational lung disease caused by exposure and development of type for hypersensitivity to beryllium or beryllium compounds. Beryllium is derived from toxic minerals and mainly used in the aerospace, defense and electronics industries. The microscopic appearance has been described as closely mimicking sarcoidosis, but there are some differences. Interstitial inflammation and poorly formed granulomas that is not usually a feature of sarcoidosis and resembling hypersensitivity pneumonitis may be helpful in distinguishing berylliosis and sarcoidosis. Next is hypersensitivity pneumonitis, which is also known as extrinsic allergic alveolitis, and it represents an immune-mediated reaction to a variety of inhaled antigens and chemicals. The most common causes of HP are microbial and avian antigens. The two most common forms of HP is farmer's lung, which is caused by bacterial and fungal antigens, and pigeon's breeder's lung, which is caused by avian antigens. HP has been classified as occurring in acute, subacute, and chronic forms, although there are no widely accepted criteria to distinguish these various forms. Most lung biopsies are obtained from patients with the subacute form of HP. The next one is hot tub lung disease, which is often associated with exposure to MAC when present in aerosols from indoor hot tub, as well as swimming pools, showers, and humidifiers. High-resolution computerized tomography findings are usually diffuse centrilobular nodules and ground glass opacities, as well as cavitary nodules. Hot tub lung can be suspected but not diagnosed based on biopsy findings alone. Definitive diagnosis requires a history of indoor hot tub use or exposure to aerolized water contaminated with MAC. The next one is eosinophilic granulomatosis with polyangiitis, which is a multi-system disorder mostly affecting adults. It is associated with asthma in 95% of patients, and lungs are one of the most frequently involved sites. The diagnosis includes asthma, eosinophilia, neuropathy, non-fixed pulmonary infiltrates, and a biopsy containing a blood vessel with extravascular eosinophils. For findings, granulomas are usually necrotizing and often appear as small groups of palisaded histiocytes surrounding foci of central necrosis. Next one is rheumatoid nodule, which is a rare disease and represents only 0.2% of cases of pulmonary granulomatous diseases. For the histopathology, the nodules are palisaded granulomas with a central area of eosinophilic or basophilic necrosis. These granulomas are surrounded by palisaded histiocytes. The presence of multinucleate giant cells, neutrophils, and eosinophils within the palisaded histiocytes is unusual and may suggest another diagnosis. The diagnosis of pulmonary rheumatoid nodule can be confidently made only if an infectious etiology is excluded and if the patient is known to have rheumatoid disease.
The difference between infection and granulomatous polyangiitis (GPA). The reason why we differentiate between two of these are because GPA can mimic infection. We can compare them by granulomas, necrosis, epithelioid size, and many more. In infection, granulomas may contain multinucleated giant cells and organisms identifiable on stain, such as Gram stain, whereas in GPA, granulomas are surrounded by vasculitis and giant cells are rare to be seen. In infection, the presence of necrotic debris often mixed with neutrophils and microorganisms. In GPA, irregular necrotic areas bordered by palisading histiocytes. Necrosis in GPA is geographic and blue. Epithelioid cells in infection are prominent, meanwhile in GPA, it's scattered and interspersed with inflammatory cells. Stain and culture are crucial to confirm infection etiologies, whereas GPA diagnosis is based on clinical pathology correlation. Serology testing, such as CA and CA. Next, differentiate between sarcoidosis and berylosis. Sarcoidosis is unknown, likely immune dysregulation triggered by environmental or genetic factors. Berylosis is a chronic granulomatous lung disease caused by exposure to beryllium. In both, we can see non-necrotizing granulomas, yellow lymph node involvement, and lymphangitic distribution of granulomas, whereas we can only see interstitial inflammation and poorly formed granulomas. In berylosis, for diagnosis, sarcoidosis has elevated ACE levels while beryllium we use BLPT for confirmation. In conclusion, pathologic diagnosis is difficult and often use etiologic agent detection inside granulomas or culture. Necrosis in granulomas is not a reliable sign of infection, as it may has or not. Every disorder has unique features to differentiate and this an accurate diagnosis because of different treatment.